We move on to an overview of premium IOLs by Dr. Chitra RAMAMURTHY.
A very good morning to one and all of you and chairpersons and the moderators on the dais. So mind you in the next 15 minutes to brief you about premium IOLs and what helps us to decide on which patient to select. So basically, we stand at a point in ophthalmology wherein we are planning premium IOLs largely to replace the cataract and give visual independence without glasses. And there is also a segment of patients, lens or may have very early cataract or a dysfunctional lens in the syndrome, wherein there is some aberrations which have started occurring in the eye, in the lens. So because of which the patient has a subnormal quality of vision and desires to have his cataract surgery done. So we have myriad of choices now. We have the monofocal lenses, which gives them good vision for distance. We have monofocal lenses with EDOF property that gives some range of intermediate vision. There are pure EDOF lenses. There are again hybrid lenses, which has a multifocality with EDOF property and the trifocal lenses. Now, I'll be detailing you on all of these. But what is most important from that slide is there is a range of lenses which are available, and the very short counseling time the patient has with us, we need to convey it all. So we need to substantiate it with information which is there in the print media, the brochures, which is there on the social media, and every other way to ensure that the patient is well informed. When we talk of visual quality, it is a balance of three interrelated factors. One, you have to know the visual acuity of the patient pre-op based on the Snellens and the log marks, and also understand whether what is the spherical aberrations which are there. Like a person could have, normally would have a positive spherical aberration in the cornea with the negative spherical aberration on the lens, which is getting counterbalanced. But as the lens changes start occurring, the aberrations, spherical aberrations in the eye, in the lens changes actually become from negative to positive. So there is induced spherical aberration. So you would look at implanting an intraocular lens in the eye which has negative spherical aberrations, which will counter the positive spherical aberrations on the cornea. The other important thing we also know, there is something like chromatic aberrations, which is there in the human cornea, where that is why the blue light gets deviated most. So those optical lenses, which are going to have a high Abbe number, means that the dispersion of the light is going to be less. A low Abbe number means the dispersion of light is going to be more. So more the dispersion, more the chromatic aberration. So you would like to give a lens which will counter the aberrations of the cornea, which would have lesser chromatic aberrations. The most important thing is you need to know what is the efficiency of the intraocular lens which you're going to place, and that is the defocus curve, which I would explain to you. We also need to know what is the property in the optics, that normally when you start looking at premium opticals, which doesn't give vision only for distance, but also at intermediate and near, there are certain things in the optic where there is some amount of loss of light and loss of contrast sensitivity. So all of these have to be factored in. But most importantly, we have to thoroughly evaluate the patient, do a perfect biometry. We have to tell the patient that besides what you expect, there is some amount of brain adaptation which is going to occur, which will allow you to get a bifocal or a trifocal vision. And also try to explain to him the optics of the lenses to an extent that he has to be prepared with some kind of a glare and halos. So it becomes necessary for us to look at the tear film layer, the lipid layer on the meibomian glands, and treat it accordingly. Look at the cornea, whether the endothelial count is defective or fugues, which itself could cause glare and compromise vision. Do a topography to understand whether it is a symmetric topography, there is no irregular astigmatism. Do an eye trace to understand whether the higher order aberrations are more on the eye or the angle alpha and the kappa. And also do an OCT macula, whether there are some subclinical pathologies which would take away the contrast sensitivity, which might already be taken off by the premium lenses. We also need to measure both eyes. Even if the other eye is pseudophakic, it gives us a lot of information. Use the latest generation formula and treat the astigmatism, even if it is just 0.75 diopters. We need to understand the personality of the patient and explain to him what small quantum of quality of vision he might compromise with a particular premium IOL, and also convince him that neuroadaptation is effective. Now, a tall man who has a long outstretched arm would be fine to do a read on the iPads and may not mind wearing reading glasses for near vision, whereas a short guy who has a high myope, who has a habit of holding his books too close, would definitely want a vision wherein the distance and the near is very good. We also need to see what is the pre-op refractive error of the patient. A high hyperope, who's tired of wearing glasses constantly for distance and near, would be very amenable to going in for these premium multifocal or trifocal lenses, and so would a high myope be. But a moderate myope who enjoys to see without glasses for near, he would not be easily amenable, and you have to give him the best correction. So you also need to see the tried platform, hear from your colleagues, try it on your patients, look at which design of optics is more effective, and also understand the defocus curve. Now, defocus curve, I already alluded to, is a real world or the best objective measure to understand what is the range of vision of that particular intraocular lens. So how do you measure defocus curve? You correct the patient fully for distance, and then keep on adding a minus 0.5 diopter lenses in his eyes till the point at which he can still see. So that gives the range of vision to which, even after blurring his vision over the intraocular, the spectacle lens, he's able to see. And these are some classic defocus curves of an EDOF and a trifocal. Now, what other important thing? We already know monofocal lens gives great vision for distance, but keeps the patient spectacle dependent. So what we need to understand is, when a wavefront of light hits an obstacle, some portion of the light goes for distance, that is zero order, some portion of light goes for near, that is the first order, and some portion of light goes for very close, that is a second order. And that very close is actually a light which is lost. So what was seen was, in the bifocal diffractive lenses, 20% of the light is lost, and which is the reason for the reduced contrast. The other thing with the bifocal lens you also see is, there are two focal lengths. So when one object is in focus, the other object which is not in focus creates a defocused image, which is the cause for the glare. So then, of course, we need to understand. So what happened was, they came in with the low ad diffractive lenses initially, wherein to ensure that the dimmer image, the near image, does not compromise distance, they gave less energy, light energy was given to near. But then what it compromised was the quality of near vision was not good. Then came the EDOF lenses, wherein they used the optics such that the patient had an extended depth of focus, was available. So there was no overlapping of images which happened with the bifocal lenses. There was no secondary out of focus image. However, these EDOF patients had great distant vision, good intermediate, but the near vision was compromised. As far as the EDOF, just briefly understanding the different ways that these lenses were designed was, one was the play of spherical aberration. The positive and the negative spherical aberrations were played around with in a mini-well lens. There was the pinhole effect of lenses which was available with IC8. There was some lenses which gave a little lesser ad for near and gave that EDOF property. And there was a particular lens called Vivity, wherein they raised the platform and increased the curvature in the central part of the cornea, which gave a 1 to 1.5 intermediate vision. While all this was happening, there came the trifocal lenses, which gave great distant vision, near vision, and also a decent intermediate vision. How did it give us 3 points, focal points? Essentially what it did was, it ensured that the loss of light was minimized in these designs of lenses, and these are the AT LISA, fine vision, and pan optics, wherein they have given the intermediate vision either as 80 or 60, in which they have optimized based on the needs of the patient. While this was happening, a lot more also happened. Then came the monofocal plus lenses, or the enhanced monofocal lenses. What they did was, they just gave a little bump in the central optical zone, which gave a little 0.5 ad. So just gave that little bit of landing zone, a broader landing zone, great distance, and little bit of intermediate, which is provided with the iHands and the Vivinex Impress lenses. So then there were a lot of lenses for us to choose from. What was most important is we need to put the patient on a toric calculator and check whether there is astigmatism, and if that astigmatism is there, treat that astigmatism along with these premium lenses. Now I'm going to show you examples to make it more interesting. Now this is a 57-year-old teacher who wants to be off glasses, high plus power, a corneal endothelium is good, the macula is good, but then if you see the eye trace, you can see that the point spread is very disturbed, so must be because of the lens changes, and he has astigmatism, so we decide to put a trifocal in one eye and a trifocal toric in the other eye, and the patient was happy. This is fairly straightforward. Here, if one eye was seeing a little less one year, you could match it with a little micro monovision in the other eye and still keep him happy without mixing or giving another design of lenses. This is a 64-year-old retired man, father of a pediatrician, wants spectacle independence, but has to do night driving because he gets very nauseous if he doesn't drive because of motion sickness. But so for what we did, we noticed that the astigmatism component was not very significant, did an EDOF on one eye, but the other eye had very early cataract. We told him that we would give him a little monovision of myopia in the other eye so that he gets good near vision, and he was happy at that. This is another patient who is a 42-year-old female who wants spectacle independence. She has cataract only in one eye. We did tell her that all parameters were fine, but then she needs a cylinder correction, trifocal toric. Is she okay for those visual disturbances which might happen by a unilateral surgery? She was very keen on a trifocal, and she did well. Now this is another patient which I'm going to show you, wherein this patient is a farmer, okay? He wants spectacle independence. His eye trace shows lot of aberrations on his cornea. So then I would not risk it with this man. The topography is normal, but then the ocular health is also normal, but I would only place an enhanced monofocal, give him great distant vision, some kind of intermediate vision as a buffer, and just leave it at that, because aberrations do not go with these very high premium lenses. This is another female who works on the computer, again a high plus power. She's a diabetic, she has MACTEL and moderate diabetic retinopathy. No way would I put a trifocal, because a trifocal may compromise with a contrast. I would definitely put her trifocal, monofocal a toric lens for her. This is another patient who again is a male, has significant astigmatism, but has a lamellar hole in one eye, so he needs a combined vitrectomy cataract in one eye. The other eye, he needed a toric monofocal, and that's how we managed. So what you also understand while I'm showing you all of this, we need to do an OCT mandatorily in all patients, at least in premium IOLs, because in 13.7% of these situations, the OCT picks up a macular pathology which was not seen on a routine fundus evaluation. So you need to be so optimal in these premium IOL patient selection. This is a post-laser vision correction. Majority wanted mini monovision for the other eye, but there were patients who were ready to try a EDOF, and that was the popularity seen in this AAO spotlight study. What is most important when you're doing a post-LASIK eye is, was the patient very happy with the quality of vision after his refractive surgery? Was the ablation bed fairly centered? No irregular astigmatism? No problems of near vision, night vision? He had a good ocular surface, a very highly motivated patient. Go ahead and put a premium IOL. Of course, you need to do the topography. You need to look at the comparison between different biometers to see there's no irregular astigmatism, there's no difference in astigmatism between the two modalities. Now, this is a myopic LASIK patient. She has a little induced positive spherical aberration in her lens, so on a cornea. So what you would do is, you would want to place a negative spherical aberration lens in her eye. And majority of her lenses available have negative asphericity, and she could do well. And she wanted an EDOF toric and got done with it. Now this is a hyperope, a 44-year-old hyperope. He has a central steepening on the topography, that red which you can see, and he has a lot of negative asphericity which is induced in the cornea. I wouldn't want to try a premium IOL. I would use an enhanced monofocal toric, which is also in the premium category. Finally, when would I put a monofocal lenses and still treat it as premium is when the patient has significant macular pathology, has glaucoma, post-LVC, has irregular bed, decentered ablation, corneal higher order abrasions are less. These are the patients when I will say please put a monofocal and not look at a premium IOL. So basically, the whole gamut of information which I tried to thrust to you in the last 15 minutes does tell us there's a huge range of development in the technology of the newer lenses which are coming in, but we have to customize our lenses based on the need of our patients, and if you have discussed it well and do an optimal surgery, you have done it all. Thank you.